Well, hello once again and welcome, or welcome back. My name is James Coplan, MD. I'm a developmental pediatrician, retired from active practice, but still interested in sharing what I know about autism spectrum disorder. Hence this series entitled ASD in 3 Dimensions. Tonight, we're going to recap where we've been up until now, and I apologize for missing my deadline from yesterday. The Jewish holidays put me behind by a day. But with that in mind, what I'd like to do is revisit some of the main points that we've covered in the preceding several weeks and then go on from there. So thank you for sticking with me, and let's jump in. We've developed several principles over the past few weeks. The first one being that atypicality can range from mild to severe, or anywhere in between. And here we have a table that shows the areas of atypicality, and I know that the DSM has reduced this from 4 areas to 3. We'll talk about that another time, but call me an old curmudgeon if you want to. But I think that it's still worthwhile to consider 4 areas, one being social interaction, the second being language, the third being repetitious thoughts and behaviors, and the fourth being sensory motor issues. And within each of these areas, there's a gradation of involvement from profound to extremely mild. And furthermore, there's also what we can call a natural history of autism spectrum disorder for improvement over time, irrespective of treatment. So any given individual can have any degree of impairment in any of these 4 areas. And over time, there's a highly predictable sequence of changes. Now, not every child or person affected with spectrum disorder goes through all of those stages. Some people show a great deal of improvement, other people show not as much improvement, and thereby hangs the tail of the 3-dimensional model that we're working up to. But suffice it to say that there can be different levels of involvement in each of these areas. And for purposes of creating a model of what we're talking about, we can simplify a little bit and reduce all of those features in all of those areas to a horizontal axis that represents severity of atypicality. And I know that's a bit of a simplification, but any model to help us think about something in a global way always involves a bit of simplification. So here's our model that shows a horizontal x-axis on a graph of atypicality ranging from severe to moderate to mild, and then over on the far right you see the word normal in quotes because I don't think any of us is really normal. And in fact, there's no sharp boundary between what constitute the mildest of the mild of persons with atypicality on the left and then persons who are, quote, normal on the right. And there are quite a few people who kind of straddle this boundary or who evolve over time from being clearly on the left-hand side to being way over here on the right. So atypicality can range from mild to severe. There's no sharp boundary between atypical and, quotes, normal. And atypicality has a natural history of improvement over time, irrespective of treatment. And when a physician uses the term natural history, what they're talking about is the evolution of signs and symptoms of a condition over time. And then the second basic principle that we've articulated is that any degree of atypicality can be accompanied by any level of IQ. There's nothing in the definition of spectrum disorder about intelligence, and there's nothing in the definition of intelligence about atypical behavior, and that's as it should be. Then we introduced a graph to illustrate the various levels of intelligence. Average on most standardized IQ tests is set at 100, And there's something called a standard deviation, which is a measure of the spread of the scores around that average. One standard deviation is 15 points on most instruments, so that two standard deviations below the mean or below the midpoint would be a score of 70. That's considered the cutoff, below which scores below that are considered to be in the range of intellectual disability, and the various degrees of intellectual disability correspond to how many standard deviations below the mean the score lies. And then above that hypothetical or calculated average of 100, there's high average, and then superior and very superior, all the way up to genius level. So this is a scale of different IQ values. And when we stop and think about how to measure intelligence in a child or an adult, but I'm talking mainly about children at this point, with atypicality, we need to look to skills that are not going to be impacted by the atypicality. And what would some of those be? So cognitive skills that are relatively independent of atypicality include adaptive skills, such as the use of a spoon. There's nothing about having autism spectrum disorder, broadly speaking, that should delay the acquisition of the use of a spoon. The spoon is one of the earliest tools that children learn how to use. There's nothing in the clinical manifestations of spectrum disorder that should delay nonverbal problem solving. And what are we talking about there? Well, object permanence, the idea that if something is out of sight, it still exists. If something falls off the edge of the table or you cover it with a cloth, I can still go looking for it and it'll still be there. The use of a crayon as a writing tool instead of as a teething object is another example of tool use. And typically, the use of a spoon comes in around a year of age. The use of a crayon comes in 12 to 14 months of age. You ask the mother of a 9-month-old, would you give your child a crayon and turn your back? And the mother will say no, because he would chew on it. You ask the mother or father of a 14-month-old, and hopefully the father as well as the mother would say, no, I wouldn't give my child, my 14-month-old, a crayon and turn my back, because the child would be likely to write all over the walls with it. So a crayon has transitioned from being a teething object to being a writing implement. And that should also happen in kids with atypicality, irrespective of their atypicality, if their nonverbal problem-solving skills are normal. Then the whole area of cause and effect. We talked last time about toys that have a little squeeze bulb where you can make the toy do something. Taking lids on and off, flipping switches on and off, or nowadays, of course, all kinds of electronic toys and screens where the child can push a button or touch the screen or scroll through an app. And I've seen children 14, 16 months of age doing that amazingly. Gross motor skills are not really very strongly tied to cognitive development. Most children with intellectual disability walk within the normal limits of the expected age. But on the other side of the coin, if you see a child who has gross motor delay, not walking at 16 to 18 months of age, and if it's due to a problem as opposed to some variation, just a family variation, then the most likely problem would still be intellectual disability. So the most common cause of significant gross motor delay is intellectual disability, even though most children with ID still walk within the normal age. But basically, where the money is in the nonverbal problem solving, use of a spoon, use of a crayon, cause and effect. Those kinds of things should not be substantially delayed, or shouldn't be delayed at all, due to atypicality. And if you have a child who has delays in those areas, it shouldn't just be laid at the feet of atypicality. And then what we did last week was to take that first oversimplified x-axis scale of atypicality and then overlay on top of that the y-axis scale of cognitive levels. So now we have a two-dimensional graph. And this is where we sort of ended up last time, and I felt as if I might have rushed through the material in my excitement to get it out there. So we'll just review it here again because this is really a central point. So in the upper left, we have children or adults, for that matter, who have moderate to severe atypicality, meaning their eye contact is severely impaired, their social reciprocity is quite limited, their functional use of language is limited, at least at the beginning, strongly repetitive behaviors with, quotes, insistence on sameness, a lot of stereotypies or sensory aversions or clumsiness, the whole 9 yards, all of that. But up here, those atypical features are occurring within the context of normal nonverbal IQ, normal problem-solving abilities, and so forth. Whereas in the lower left, we have individuals who have the same degree of atypicality, but it's occurring within the context of significant overall cognitive limitations. So the upper left quadrant is often referred to as high-functioning autism and the lower left as low-functioning autism. The degree of atypicality is the same. What differs is the level of IQ. Then in the lower right, we have children or adults whose larger issue is intellectual disability, but who also have a smidgen of atypicality. And unfortunately, that smidgen of atypicality can go a long, long way towards serving as an additional impediment in the presence of intellectual disability, as opposed to what we have in the upper right-hand quadrant, which is individuals with mild atypicality and normal general intelligence. So if the individual is hyperverbal and socially intrusive and maladroit, that's what Uta Frith and Lorna Wing called Asperger syndrome, even though that's not what Asperger himself considered to be Asperger syndrome. So the hyperverbal, intrusive, socially awkward individual, or what also was the term used, pervasive developmental disorder, not otherwise specified. In other words, not numerically severe enough to meet the criteria for autism, but still clearly on the spectrum. And then over on the far right, remember there's no sharp boundary between normal and abnormal or between atypical and not atypical. I think that's a better pair of terms than normal and abnormal. Are these individuals who have not quite autism, semantic pragmatic language disorder, nonverbal learning disability, broad autism phenotype, sensory integration disorder, and we'll talk about those in more detail. But those are kind of in the borderland, the twilight area between fully expressed spectrum disorder and no atypicality at all. So the third principle that we articulated is that long-term outcome is governed by the joint impact of the degree of atypicality and the level of intelligence. And this is something that a lot of therapists and service providers who are focused on the atypicality don't feel comfortable talking about or don't want to get into, and that's understandable, but it's really important, especially if you're a parent coming at this, to be cognizant of the fact that your child's level of intelligence is going to be hugely important for its own sake, as well as in terms of the influence that IQ has on the natural history of the atypical features. So what are we talking about there? Well, now we're back to the iceberg that we left off with last time, and the little expression, the warmer the water is, the faster the ice melts, because the chunk of ice is meant to signify or represent the degree of atypicality, and the water temperature is the IQ. And if we go into this in a little bit more detail, here we have that IQ scale that we talked about before, and I want you to think metaphorically about temperature, water temperature, and the higher the IQ, the warmer the water temperature. So here we have, again, an XY graph with atypicality on the horizontal or x-axis ranging from severe to mild, and then level of intelligence on the vertical or y-axis ranging from profound intellectual disability down here to genius IQ up there. And now we have those same four quadrants that we were looking at a few slides back, but we can think about it visually. I'm a visual learner in case you haven't figured that out yet. And in the upper left-hand quadrant, we have individuals who have IQ in the average or better range with severe atypicality, and this is that iceberg. It's a big iceberg, but it's floating in the Caribbean. And what's it going to do over time? It's going to melt, and it's going to melt dramatically, and we'll talk more about that in a few weeks. Down here, you'll notice the iceberg is exactly the same size. Thanks to Photoshop, the iceberg is exactly the same size, but now the iceberg is floating in the Antarctic. And the water is, actually you can see it's pack ice down here. So this is low functioning autism. The atypicality is the same, but the context or the milieu, the environment within which we're looking at this atypicality is very, very different. And as you can imagine, this iceberg is going to have a much longer lifespan, not biological lifespan. There's nothing about spectrum disorder that limits lifespan, but the atypical features are going to persist much longer over time, and the degree of evolution through that natural history of diminution with symptoms over time is going to be much slower and much less complete for kids who start out down here. So having a low IQ is a double whammy. A, for its own sake, having the low IQ, and B, because it tends to retard or inhibit the evolution and diminution of atypical features over time. In the upper right, these are the kids who might have been called PDD-NOS or Asperger syndrome. It's the same tropical paradise, and they start out with a smaller chunk of atypical features in the first place. And a fair number of these children and some of these individuals will wind up outgrowing the diagnosis over time. So as adults, unless you look back at what they were like as children, they might not meet criteria as adults for having spectrum disorder, but they may still have some traces of atypicality. And if you go back in the history, you'll see, lo and behold, that as children, they met or would have met, if anybody had looked at them closely enough, criteria for autism. And a lot of parents of kids on the spectrum are actually here or over here, just over that border. Hans Asperger talked about that. Leo Kanner talked about that. It's a truism, and it's the case. And I've encountered that in my practice many times also. And then down here in the lower right, we have children who start out with significant intellectual disability and just a touch, just a little smidgen of atypicality. But unfortunately, within this context, even that little bit of atypicality, as I said before, goes a long, long way. The same degree of atypicality can be much more of a hurdle for these kids than for the kids up here, because the children down here aren't as adept at working out compensatory strategies. Now, so we have this two-dimensional model of atypicality and IQ, and I've been talking about the evolution of symptoms over time, but to really capture that in a graphic way, we need to add a third dimension to the graph. So put on your seatbelts if you haven't had them on already. What we're going to do is take this two-dimensional graph with atypicality on the x-axis and IQ on the y-axis, and we're just going to give it a little bit of a quarter turn to the right, like that, just a little bit of a turn. So it's the same rectangle, but now it's tilted. It's kind of going into the plane of the paper, sort of away from you on the screen. That's why I use this kind of Star Wars lettering, that screen crawler kind of lettering, to give the impression that it's receding a little bit. But we've still got those same two axes, atypicality there and IQ here. And now we're going to add time. Time is the third dimension. And when we pick up the discussion again next week, what we're going to talk about is how we integrate time into this conceptual model, and how the interaction between degree of atypicality and level of intelligence plays out over time, and how we can actually display that, and how that display can help us think about prognosis and the child's needs as they grow older, and long-term planning, and all kinds of decisions that are interwoven. So that's where we're going next week. Well, I hope you've benefited from walking through this material with me. I feel a lot better today, having gone over this with you in a little bit more detail than last week, when I do think I kind of rushed through it a bit. And if you are interested in learning more before the next blog post, which should be next week, you can go to my website, www.drcoplan.com, and there's a link there to the book that I put out in 2010 that talks about all of this in great detail. Forgive me, because back in those days, the term mental retardation was still politically correct, and that term is used throughout that book instead of intellectual disability. But other than that, I think most of what I've said tonight you can find a lot more detail about in that book. And we'll pick up again next week and walk through it again at that time. So thanks again, and I'll see you next week.